So, yes, it was not there. No, no, it was not there. It was in the Mac. It was not in this side. So now we are going to the tips for anti-VEGF. So the hot topic before we went to have a coffee. Well, we all know about ITROP and the good results with laser, but when we have the sub-analysis of the results, we find that in zone 1, the results are not so good. So you have almost 30% of failure in zone 1. So laser is not enough. And we had at the time the experience to use anti-VEGF in the adults, the proliferative diabetic retinopathy, and how good it was before the surgery. So it was just a little step to do it in the babies because it's a proliferative disease, and we began to do it. So we were the first one to make the publication of anti-VEGF, and then all the step of the papers and the experience worldwide with anti-VEGF in ROP. Now, we have all the weapons. We have different anti-VEGF. I'm not saying this is better than that one. No, they are very good. It's a good weapon, but we must know what to expect from them. What do I mean? You know that we have, again, relapse diseases. So we can have recurrences after the anti-VEGF. So the difference between them is if they recur more or less. If you inject bevacizumab, you know that we will recur 8.2%, so it's less than if you use ranibizumab. And so in my experience, and what is published, ranibizumab has the highest rate of recurrent disease, bevacizumab and aflibercept, a very similar rate of experience, although we don't have so much experience with aflibercept. What this means? We can use them. They are very effective, but we must follow up more cautiously the babies that we inject with ranibizumab. Of course, we must be cautious with all them, but this one particularly, we must be expecting some kind of recurrent disease. When to use it? So in Europe, you can use it in all the stages, all type 1, because they are on label for all type 1. What do I use? Also on all type 1 ROP. I privilege the zone 1, so the zone 1 or posterior zone 2 to use the anti-VEGF, but we can use it in all the type 1 ROP. Well, what you should never use, unless you are going to make a surgery after this injection. You must never use it if you have an extensive fibrotic high in the vitreous proliferation. You know that if you use in that case, you'll have a crunch phenomenon. So you just use anti-VEGF in that case if you are going to book the OR and make a vitrectomy. Second, anti-VEGF does not prevent ROP. So don't use it in type 2 ROP because in my hands it does nothing, and then the disease comes again. So I think the best way to use it is in type 1 ROP. In some countries, you can use it widely. So in Europe, you can use it in all type 1. In other countries, just in zone 1 ROP, that ETROP proved that laser was not so effective. Never do this. I did it once because I want to follow the rules. So never do laser in one eye, especially if you have a very posterior ROP, laser in one eye and injection in the other, because laser will induce, if it is a posterior ROP, it will induce high myopia, and you will have amblyopia because of anisometropia. So never do this. If you decide to do laser in both eyes. If you decide, or if you have just ROP very asymmetrical, you don't have ROP in one eye and you have in the other one, then inject. Don't make laser because you can risk this, the anisometropia. Then, tips. What's the problem to inject in the eye of the baby? Is the size of the eye. If you touch the lens, you will have a cataract and the baby will be blind because of anisometropia. If you touch the retina, you can have a retinal detachment. So you have a narrow place where to put the needle. And that narrow place is really narrow because in child, you have just this little, you don't have almost pars plana. If you retroeliminate the limbus, you just, oh, I don't have, do I? Okay. You just have this little, sorry, I wanted, I am not good. You have just this huge and the mechanism. So usually you have all the limits that you can print yourself because it depends on the age, the gestational age of the baby. But if you want laundry, you can use one and one of the limbs from the limbs. And when you do that in the caliper, it will be a huge area. It's not so little area like that. So the first tip is inject from 1 to 1.5 from the limbus to be sure that you don't touch the lens and that you don't touch the retina. So it's a very, you can see a normal eye and the normal baby eye, and then you can see a little one. So if you inject too much needle, you touch the lens. If you inject, so you have a very narrow space to inject, to put the needle. So sometimes that's just who does vitrectomy. Sometimes you must make an injection pre-vitrectomy, and you cannot go inside the eye because you have a retinal detachment, and you are not sure that you have a place because the retinal is detached. And if you put anti-VEGF in the back of the eye, you can touch the retina. So you can use it in the anterior chamber. So you make a little paracentesis with a 30 gauge needle and inject in the anterior chamber. It will make some kind of effect before you can go to your surgery. But that's just a curiosity because that's not what you usually do. And where do you, another thing, when you inject, let me go back. When you inject, you cannot do sometimes like other one. It's your side, but it's the lens. So you just point always in your mind this object. Yeah. Oh, if you inject in the adult, you can inject to the center of the eye, the direction, in the baby, the premature baby. If you inject to the center of the eye, you are touching the lens on the camera. So in your mind, you are injecting, looking, facing the optic nerve. Okay? Not to touch the lens. So not like this, like in adults, you face the center of the eye. Here, you face it's looking as in your mind on the optic nerve, not to touch the lens. Now, where to perform it? It is different according to your reality, your country. Most of the people like to do it in the OR. It's safer for the endophthalmitis. Most of other countries have to do it in the NICU because they have no room in the OR. And some, like I, in my NICU, I can do it in a dedicated room exactly for injections in the NICU. Of course, in the NICU, without a dedicated room, you can have high risk of infection. But if you are careful, you can also do the NICU, the injection at the open NICU. Then in the OR, you minimize the problem of endophthalmitis and can use the surgical microscope. In the NICU, the advantage to have a special room, sterilized room, where you can do the injection is that, okay, you have less risk of injections, but the people that is taking care of your baby are specialized people for the premature babies. In the OR, no, they are specialized for other grown-up babies. So you can perform according to your realities in all these three places, safely perform the injection. There is a very interesting multi-center paper and work that was done about how to perform objectively safely an injection for the anti-VEGF in ROP. It's called the SAFER ROP. And it's very interesting because this group, not all the world, we can have a small needle, so a special needle to inject anti-VEGF in the eye. So this is what they call the short needle. If you can have it, it's wonderful because it skips the problem to touch the lens. It's so little that this little needle is in the space almost never, even if you wish. But if you are 1 to 1.5 millimeters look facing the optic nerve, with this needle you will never touch the lens for sure, and will never touch the retina, because sometimes residents can cross one eye to the other and put all the needle inside the eye. What do? I don't have this needle. I have 30 gauge needle regular. I just put a little of this needle inside the eye of the baby. But the SAFER advises you, if it's possible, to use this 30 gauge needle 4 millimeters. It's the most safe way. Even if you are resident, if you're not very experimental with the injections, it's very safe to use this needle. Now, how to avoid the endophthalmitis? My biggest fear is endophthalmitis, not touching the lens, not that's technique, but endophthalmitis, you cannot control it. They are they don't have their immune system developed, so they are immune compromised babies, and that's always very frightening to me. So you must use betadine or the local ocular betadine we do have is, or the skin betadine for 3 minutes. Well, there are some people like me that is obsessed with this. So I use before the solution for the skin, 5 minutes while I am asking for the things, opening things. So before I put on the table, I first perform one first disinfection, then before the surgery, really, the injection, I put the betadine inside the eye. So I do 2 sterilizations, 2 betadinizations, and then when I take the needle, I again put a little bit of betadine. The risk of endophthalmitis, that is what I'm telling you, is frightening to me, because whatever you do, it will be a lost eye, at least for the sight. You may maintain the eye, but not for the sight. So be aware of the things that can originate an endophthalmitis. So a nasolacrimal ductus obstruction, when you put your finger in the lacrimal ductus and it can fuse from there. So in that case, I don't make injection. And conjunctivitis also. Usually conjunctivitis need at least 3 days to be completely without risk of endophthalmitis if you inject. If you can wait those 72 hours, it's okay. But if you cannot, that's the only indications for me to do laser as first treatment. So try to hold the needle never near the face of the baby. So when you take the needle, when you take the injection, try not to hold it where you can have vaporized things, because they all have something in the eyes, something in the nose. So try to, the last thing to do is to take from the table the needle and to injection. Never cross from one side to the other to contaminate the needle. What do I do? So I open, so usually this is my room. So this is in the NICU, a special room where we can do this and to perform other surgeries to close the heart, the foramen ovale, so they can do also other surgeries in the NICU. So very careful. I have gloves, I have everything that can be asepsia. When I do twice the 2 eyes at the same time, I cover one because I don't have room to have two. But if you have two tables to do two procedures, that's okay. But you can cover one and put again the other table on the first one, but before anything. So before the baby is there, before anything, I cover, dress all the tables. Now, tips. Be always sure that you don't have air inside the needle because you are going to put 0.02 of some kind, whatever drug you put inside the eye of the baby, or 0.01. And if you have a bubble, you put nothing in the eye. And then you stay surprised that, oh, it didn't have any kind of effect. So I am obsessed always with this, just to take all the bubbles of air from the needle. And you see that the needle has a reservoir, so be sure that there is no air in that reservoir. Then the babies have multipathologies, and most of the times they have, I don't know how to say this in English, a stoma. Yes, a stoma. So be sure that you isolate. Usually I put something around the baby to be sure that nothing can contaminate what I'm going to do. Then oxybuprocaine, then betadine, and then, so let me just show you how I do. I protect all the tubes because suddenly when you are pushing them up, the baby can feel bad. And then you have to take everything without pushing any tube. So over again before I put. And then the baby next again shows very well where to make the injection. I do it by myself. And after this, it's very important that you see the patency of the central artery of the retina. So you must be sure that the retina is being filled with blood. So again, isolate everything. See, I don't put all the needle, just a little bit of the needle. And at the end, always look at the central artery of the retina. Yes, it's huge. I don't have the, yes, I don't have lesser than this. Yes, so I try to do it just to introduce a little bit, not this one. So 4 millimeters. In your head is 4 millimeters, just a little bit. You can do it, you can try it, because I don't have the safe syringe. Now, I used to cover the eyes after the oh, just, yes, you're right. And when you have the infant flow, that mask that make a lot of vaporized air around, I try to turn them to this little inside the nose, not to make must air around where you are doing this the procedure. Usually, and quite often, we do bilateral injection. So it's all the same. The procedure is all the same, and the important is that what you put in an eye, the table is exactly duplicated. So you don't use anything that you use in the eye in the other eye. So separate, like in the vitrectomy, completely those procedures. Okay. It's what's possible. That's an issue. So the ideal would be separated vials from separated drugs, but you have compounding pharmacies in your hospital, so you cannot do this most of the times. But the ideal is separated vials from separated drugs, so you can be sure that some kind of reaction or some kind of endophthalmitis contamination because of the vial is not bilateral. Yes, that's sure, but it depends on your hospital. So bilateral is completely different tables. So duplicate everything. Now, follow-up. So the follow-up, to be sure that you don't have endophthalmitis, you must see the baby 48 to 22 hours after. You can see 24 hours after, but sometimes the endophthalmitis don't begin at 24. They begin at 28 or 72. So it's very important to see the baby 3 days after you inject it. Then, of course, this is to prevent or to see if you have any kind of endophthalmitis. But to follow up the eye, then you see it weekly. So it's different things. To see if it regresses is one thing. To follow up endophthalmitis is another issue. So endophthalmitis to me is the most terrible complications, but you can have other complications, but they are minimal, they are residual if you do the correct technique. Recheck when, as I tell you, endophthalmitis, I see the baby 3 days after, but to be sure that it regresses, you can see it weekly. What do I mean? Plus disease disappears in 24 hours. If you see the baby 1 day after, you don't have almost plus disease. But the disease itself just begins to regress 1 week, in 1 week. So you can see the day after without plus disease, but then you must follow up. So the day after is like this, this plus done. 1 week, everything is calming down. So don't expect in the next day that all the stage 3 disappeared. No. It will disappear in 1 week, and then 2 weeks, and then it stops, and then the retina begin to grow quietly to the periphery. And that's the beauty of anti-VEGF, is that the retina can be vascularized normally. Why normally? Because a few years after beginning to use anti-VEGF, we found these peripheral vascular areas. And now this is one of the problems. What to do with this persistent avascular retina? Is it quiet? Is it not quiet? Which area should we follow up? Which area should we laser? When we have angiography, really, you can guide yourself by angiography, but you have two strategies. One is systematic prophylactic laser of these areas, and the other one is to follow them, and just if there is some kind of aggressive activity or no, I mean, if you know that it's really having any kind of persistent activity, you should do laser. So there are a school that does systematic prophylactic laser of the vascular area. So when you reach 60 weeks of postmenstrual age, if you have angiography, you can do it. If you don't have angiography and if you have this power, you can make it. So the laser of this area. Now, we don't know really how much laser you need it because you don't have studies. I mean, is it a confluent like in the treatment or just a scarce laser? We never know. So I think we need treatment for some kind of studies to understand what to do with this peripheral vascular area. So as needed, I and my school do as needed treatment. What I mean, so if you have a recurrent ROP, you'll do laser. But if you don't have a recurrent ROP, you can follow up them. Sorry, I want. Okay. So if you have a way to manage to make the follow-up of the baby a longer follow-up with angiography, we just make the lasers of the babies that have a torpid or some kind of activity in that interface to the peripheral vascular area. So what do? I see the baby 1 week after the treatment. Then I see them monthly. To the first 3 months, I see them weekly. Then monthly until 70, not 60, but 70 weeks postmenstrual age. And if you have a complete vascularization, I see the baby just 1 year at 1 year and discharged to the normal appointment. Now, if I have some kind of power, I make angiography. And if I have some kind of activity, I can do laser. So if I cannot follow the baby properly, if I cannot see the baby again, I make laser of that peripheral avascular area. I try to do just little laser, and I was not comfortable because I could have occult neovasals years later. So I decided to do a laser more dense laser when I have a peripheral avascular area and if I have some kind of activity. If not, I usually see the baby each 2 months until 1 year of age. And then I usually do another angiography as needed. Or, I mean, if I see any kind of activity in the periphery or if I see any kind of activity in the posterior pole where you can see that you have again VEGF in the eye, I can perform fluorescent angiography. But until now, there is not absolute follow-up and no guideline absolute because we don't have studies that can prove you that each one of these ways is a good way. So I think if you cannot see the baby, if you feel comfortable to make laser of the peripheral vascular areas, do it. But don't forget that you have to follow up. It can have some kind of complications, even if you do laser. So don't let the baby go. If you can do this kind of not treatment, but the follow up. If you can follow up the baby, if you can do angiography, if you can, the parents come to you, you can have safely years of peripheral vascular areas without no problem. So I've got 15 years of peripheral vascular areas with no problem. But I've got a baby, a girl with 60 years old, that she had a recurrence. So it's not ROP, I think it's fever. But she had a recurrence, and you never know where the genes mix with ROP. So we must always follow up, and we don't have the absolute word about the follow-up. But Ihab, you will tell us about the PAR. You are, so I could speak about PAR and you didn't tell me. Okay. The boss said no. So easy. Okay. But next time we'll speak about peripheral. About PAR. So that's my work. That's the presentation I had. And we still a lot of questions. I mean, it's a weapon, it's a good weapon, but we still don't know what are the limits of this weapon. So we still have a lot of questions about anti-VEGF. And as Suhadra said, we have laser, we have anti-VEGF, and now we have surgery, isn't it?